Dr. McGrath, you can start.
Okay, good evening, everybody. This is Dr. Lynn McGrath. I'm one of the assistant professors of neurological surgery at Weill Cornell Medicine, and we're presenting Spine Time. I have the pleasure of pinch hitting tonight for my colleague, Dr. Roger Hartle. We're going to be talking about healthy bones, healthy spine, how osteoporosis affects your back and your neck. And one of the real advantages of being able to work at a place like the Multidisciplinary Spine Center at Cornell is the fact that we have access to colleagues that span the entire spectrum of medicine. And we can call on the expertise of specialists like the ones we have tonight. I want to introduce you first to Dr. Penny Andreopoulou. She's an endocrinologist at the Department of Medicine at Cornell, focusing on osteoporosis and metabolic bone disease. You can call her Dr. P, Dr. A, Dr. Andreopoulou, whatever you like. But she's someone who really focuses on the health of the bones, how to prevent osteoporosis, how to treat it, how to mitigate it. And she'll be talking with us first tonight. And I also want to introduce Dr. Boddu, Dr. Sri Boddu. He's likewise professor of radiology in the Department of Neurological Surgery at Cornell. And he also works with me at NewYork-Presbyterian, Queens. He sees a lot of patients that have suffered the consequences of having osteoporosis. He helps to treat patients with compression fractures and things like that. And he's going to go into some of the options for patients that are suffering some of the downstream consequences of having poor bone quality, poor bone health, osteoporosis. So I'm going to get right into letting our two guests this week tell you about bone quality, bone health, how to get it, how to prevent the problems associated with osteoporosis and metabolic bone disease. And I think we'll just kind of keep things natural and bounce back and forth, and hopefully we have a good time tonight.
Thank you, Dr. McGrath. Good evening to everybody. So it's my real pleasure to actually do this talk. I really believe a lot in diagnosing and managing, preventing fractures and osteoporosis. It's kind of my goal in my life to do that. And I want to start a little bit about introducing you to our bones, right? So what are our bones? What do they do? The bones, specifically focusing today on the vertebrae, right? The bones that comprise our spine are really a beautiful structure. As you can see here on the left, we have a normal structured bone. It consists of many little bridges there that are called trabeculae. And it forms this honeycomb structure that has the main purpose of being able to support our frame, support our weight, right? Support obviously our head as far as the vertebrae in our neck are concerned. And without being exceedingly heavy. It's not a solid structure. It's really a nice light structure that is able to withstand a lot of force and a lot of pressure. And a normally structured bone has enough bone mass in it and a good porous structure that is able to achieve that goal. However, on the right side, we see a bone that is completely deranged. Those trabeculae, those little bridges, are very thin. The pores are very erratic. The structure starts to change, and that really affects the strength of our bones and the vertebrae in particular here, and that can affect the function of our spine. So osteoporosis is a skeletal disorder that's characterized by compromised bone strength that leads to a higher risk of fracture, of a crack in our bone, a broken, a crumbling bone. And bone strength reflects the integration of two main features. So one is bone density, and the other one is the quality of our bone. Both are very important. Next slide. It's a serious public health problem. I just want to mention that it's not something that's specifically limited to very old people, as we're we're brought to believe. 14 million Americans over age 50, 80% of which are women, are affected by osteoporosis. In America, we have over 2 million fractures a year, more than 5,000 a day. And it's very common. 1 in 2 women over age 50 and 1 in 4 men will have a fragility fracture in their life. Very common. And the most common of these fractures, as we can see on the right, are really vertebral fractures, fractures in our spine, followed by wrist and hip fractures and other fractures. So what is the problem with that long-term? Long-term is that less than 50% of people that get a fragility fracture are able to get back to their normal life. They can't. And they are often followed by complications that can lead to increased risk of death. We know that there is a 15% higher risk of death after a vertebral fracture in the first 6 months after the fracture, and after a hip fracture, actually 20% of people die within a year. So this is really not a light event that just causes a little bit of discomfort and pain. This can be really serious. And people that get fractures are very prone to getting more fractures. The cost to our economy and our health system, of course, is enormous, trying to really address all these fractures. Next slide. And we don't want you to get to this, basically. This is the famous Dowager's hump that, again, we associate with old age. We really want to prevent that. But why does this happen? Well, as I said, our spine is made of these beautifully constructed vertebrae. And if those are brittle, if they're thin, they don't have enough bone mass, or if their construction is really broken down, then our own weight or a low impact movement, such as, for example, bending, can lead to a cracked vertebrae. And here we see a crushed vertebrae on the right side. As soon as you get one, you're at very high risk of getting another one. Most people get another fracture within a year after the first one if they remain untreated. And that's because the way our weight falls on the rest of the vertebrae is now not within the usual expected distribution. So that creates a major problem. You get one, you can start having like a crumbling spine, and get to our picture on the left. So how do we know we have osteoporosis? We really don't want to have this, right, for anyone. Next slide.
So before we go on to the next slide, two people have asked about what causes the deaths after these fractures.
What causes the death? So when you get a fracture, you can actually get certain complications, either from surgical procedures or from like thrombosis, clots, from being sedentary, from not moving. You can get deconditioned. You can then be prone to infections. So there's a whole cascade of medical issues that follow a fracture, mainly because of the limitations in movement and pain, and from the pain. So that's one reason. Hip fractures, for example, also have the risk of surgical procedures as well. So that's how you die after a fracture. Can you reverse osteoporosis? Yes, you can reverse osteoporosis in a way, which I'll address a little bit at the end of my talk.
This is great, guys. Keep the questions coming.
So first, before addressing how you treat osteoporosis, I just want to say how you find out, because that's very important. If you don't know you have it, you can't treat it. And a very easy test to do, very widely available, cheap, gold standard, very predictive of risk of fracture, and very, very low radiation. And I emphasize this, it's less than a flight to Chicago, for example. It's a bone density. It's very easily done, and it can estimate the amount of bone mass we have in our spine, hip, wrist, or total bone density. Does everyone who has osteoporosis get the hump? I see in the chat box. No, not everybody gets the hump, but people who get multiple fractures in the spine, they can get that kyphosis, definitely. Does scoliosis increase risk or affect accuracy of Dexa? Yes, definitely scoliosis does. For example, here you can see what we see basically in a bone density report. So on the upper left side, we see the lumbar spine measurement. So the machine estimates bone density in those 4 vertebrae, and it gives us an average. And scoliosis, arthritis, all these degenerative conditions that start happening as we get older can definitely affect those measurements. And sometimes they make it more difficult to diagnose osteoporosis by bone density. So we do have to rely on other measurements as well. And this is why I have included the hip image here in the bone density in order to suspect that someone has osteoporosis, because if you have it in your hip, especially in the neck of our femur, right, not the neck of our spine, then you still are at high risk for fractures of the spine as well. So anywhere it is, it's risky and concerning. And with the bone density, we can also do an extra test if we suspect fractures. And that's one on the far right. That's a vertebral fracture assessment, which really helps us a lot figure out if there is already a compression fracture. So if you come in the office and tell me, I'm hemming my pants, I'm shortening my long dresses, or I notice my adult children are getting taller. Well, that shouldn't be happening. It's because you're getting shorter. Or if you tell me you lost a significant amount of height, I will definitely either do an X-ray of the spine or take a side image in the bone density in order to see if there's a fracture already there, because that makes it much higher to get another one. And then we have other ways of trying to figure out if a bone is brittle through the bone density. Here at Cornell, as well as generally in academic centers, we can actually assess what is the bone quality, not just how much bone you have, but where is it? How is it distributed? And we can see here 2 individuals who have the exact same bone density. It's very similar, but in the top individual, the bone is really distributed very nicely throughout the vertebra, and that keeps it fairly strong. Whereas in the lower individual on the bottom of the slide, the trabecular bone, like the structure of the bone is really altered. Look how many holes that person has there. So there's more bone in certain areas, less in others. Same amount of bone, but badly distributed. So that bone is much more brittle. So we can actually estimate that with software that we use nowadays, and it's very helpful in our risk assessment. So this is how we diagnose osteoporosis, and there's generally 2 ways, I guess, we get osteoporosis. One is early on in life, where we don't really get to the best peak bone mass in our younger years, just maybe because we just didn't inherit very good bones, or there's younger individuals that have specific conditions that affect their bones, like celiac disease or anorexia, or take medications for certain conditions. And then the other and most common way of getting osteoporosis is really by decrease in bone mass and bone quality due to aging, especially in women, where they get this dramatic hormonal change around the time of menopause with really decreasing estrogen levels. And that can also be in combination with deficiencies of calcium and vitamin D and other factors. So in both those ways, we can get to low bone mass and impaired bone quality, and then fractures. Next slide. And so what should we do about it? Well, we really have to focus on multiple ways in treating the osteoporosis. We want to preserve and increase our bone density. First of all, addressing any calcium and vitamin D deficiency, medications that can help prevent and reverse, reverse osteoporosis, prevent fractures, and then address issues like tendency to fall because of muscle weakness or poor balance with physical therapy, strengthening and balance exercises. Again, vitamin D helps in that. Next slide. And as far as medications, getting back to that original question, are concerned to reverse osteoporosis, we have to get back to the basic level in our bones. So what is really happening that we're trying to reverse, right? So in a normal functioning bone in a healthy younger individual, every day of our life, we have those cells that are called osteoclasts that do this, something we call bone resorption. So they basically break down our bone and form those pits in our bone continuously. And then cells that form bone, they go in there and they replace the bone that was lost. And this happens, they're matched. Those two processes are matched very nicely, and in balance happens like every moment of our life throughout our skeleton. But in osteoporosis, we'll see in the next slide that on the top part, we see, of course, what I just showed, but on the bottom, we see that in osteoporosis, the process of the bone resorption, the bone breakdown, is much more pronounced. So the bone formation part cannot really keep up with the bone loss. And the cells that form new bone, the osteoblasts, are enabled to properly fill those pits up to the top. So this way, the bone starts becoming more and more porous, and those connections that I showed you earlier start breaking down and make it brittle. So we really try with treatments to address, to target these two processes. So what can we do? Either we can stop the bone loss, right? By giving medications that control the cells that do the resorption. We're trying to bring back that balance, or we can actually stimulate making new bone, right? And that actually sometimes help improve that structure that is broken down. So these are the major ways. And we do have at least one medication that can actually do both. And next slide. And these are all the options we have nowadays as far as reducing risk of fractures and treating osteoporosis. And I want to point out that all of them have a pretty good efficacy in reducing risk of vertebral fractures. In order to have a medication actually approved for treatment of osteoporosis, they have to be able to reduce risk of at least vertebral fractures. And some of them are way stronger than others. And many of them reduce risk of other types of fractures and hip fractures as well. And then, of course, if I'm not fast enough and I can't prevent all these vertebral fractures, so if an unfortunate event happens and it's very painful, then I'll have to send the patient to Dr. Boddu, who's going to take over and you know, treat the fracture that already has occurred.
Thank you, Dr. P. It's a wonderful discussion for medical management side. And a fundamental question here is, why do we even need to treat these fractures? Because of the some of the facts highlighted by Dr. P. The incidence of the osteoporosis is like every 1 in 2 women and 1 in 4 men above 50 years. And so far, we don't know about exact incidence, how many fractures are happening on annual basis, because the number of fractures we see is only 1/3 of the actual fractures happening. And the rest 2/3 are just not even coming to the clinical attention. Just patients are sitting at home and attributing this to the old age or back pain, non-specific back pains. And also, once you have a fracture, your risk of having the second fracture goes up by 5 times. And if you have 2 or more fractures, your risk goes up by 12 times. And on top, there is a risk of mortality. If you have a vertebral fracture, and your risk of mortality, that is death, is almost 15% in the first year, and it goes up to 40% in 8 years down the line. So based on all these things, we need to address these fractures. An important thing is, if you get a hip fracture or a wrist fracture, you will run to the emergency room to get it treated, because these two are also caused by the osteoporosis. But the excuse is, yes, I cannot weight bear anymore, or I cannot perform my fine movements with the hand. And in fact, spine is a combination of these two, the weight bearing and the fine movements of your body. And so there is no excuse just to sit down and watch for these fractures. So, and what is kyphoplasty? This is a type of a vertebral augmentation specifically designed for elderly population. This is a minimally invasive way, and which does not involve any cut open and hardwares and general anesthesia. We are trying to avoid all those. This is an exclusive, minimally invasive, a boutique procedure. Next slide, please. And this is, we have a confirmed evidence at the level 1 clinical evidence published in Lancet proving the efficacy of balloon-assisted kyphoplasty or a conservative management. Next slide. And this is the, this is performed in a fluoroscope, under fluoroscopy, that is X-ray guidance under in the angiographic suite. Patient is lying in the prone position on their tummy, and procedure is performed under local anesthesia and sedation. There is no general anesthesia. So far, general anesthesia requirement for these cases is less than 2% in around 1,000 cases we did so far. All these patients get antibiotics, and if they are on aspirin, we are okay. We don't need to stop them, but we stop if the patient is on Coumadin, Plavix, or more blood thinning medications. And this is done as an ambulatory procedure. Patient comes in an hour before the procedure. The procedure itself takes roughly 30 minutes for each level, and patient will be in the bed rest for 3 hours after and goes home on same day. You can see the bottom picture here. That is the scars you are having. There are no stitches, just some sort of a Band-Aid we are going to place, which comes off next day. Next slide. And this is the example of how we restore the height of the vertebral body. Basically, we are putting 2 needles on either side into the fracture, and through the needle, we will use a balloon to restore the height of that vertebral body. And you take the balloon out and fill the fracture with the cement. The cement is the composition of a healthy adult bone, which is scientifically called as polymethyl methacrylate, PMMA. And it is a slightly modified version of the dental cement what they use. Next slide, please. So as with any case, procedure, it is a patient selection is a very key to the successful outcomes. And this is an example of MRI of the patient, and it shows on the right side picture, you are seeing the high signal. It's a bright, that is edema on the fracture. That means the fracture is recent, and these patients will benefit from kyphoplasty. Presence of edema is one of the very good indicators to tell who is going to benefit and who is not. Next slide. And this is the, notice this picture, these are the sequential scans. The first one on the left side, the scan was done in February. I'm not going to tell you the year. And the next picture was taken in May, and we saw the fracture, and we offered the kyphoplasty to the patient. And of course, patient, one of the common things I hear is they said I've seen more life than your age, so I know this will go down, this will heal by itself. And patient came back in September, and that is how the fracture ended up. And once the fracture ends up this way, the concern is it goes back and pushes on your spinal cord and makes you weak in the legs. And at that point, you miss the boat, and you can no longer have kyphoplasty, and you need to have an open surgical procedure, which patient ended up having. And you can only imagine the patient, in an 86-year-old patient, going through this extensive procedure, and where she don't have the bone quality to hold this metal work in the first place. So we don't want the patients to go to that point. Next slide. And risks wise, it is less than 1% risk procedure, and which means it is one of the safest procedures that can be done in the fluoroscopy or a neurosurgical site. And there is always a risk of infection and less than 1% risk of a cement leak, which can cause weakness in the legs. But I can tell you, at least here, we've done more than 1,000 cases. And so far, we have not seen a single patient with infection or cement leak causing any weakness to the patient. Next one.
Dr. Boddu, if I could interrupt you for a minute. Someone is asking if kyphoplasty is the same thing as vertebroplasty.
Yes, it is grossly, it is the same, but it's a kyphoplasty. You use the balloon to create the cavity so that you can hold the cement in a very specific location. Whereas vertebroplasty, you don't use the balloon, so the cement can spread all over. There were trials that showed the comparison of both kyphoplasty and vertebroplasty. And the kyphoplasty, the safety is more than vertebroplasty, and also the risk of a cement leak is much less in kyphoplasty than vertebroplasty. But the fundamental concept is same. So this is an important slide to answer the question, partly answer the question to someone asked to Dr. P, asking what is the cause of death in these patients. Reason why I don't favor much of a medical management is any bone in your body can heal if you are staying in the bed for a long time. In patients with a good bone quality, give or take it in 3 months' time, your fracture will heal. But in patients with a poor bone quality, that is a different situation, but eventually they will heal. But you need to stay in a prolonged bed rest. What it means is, unfortunately, the prolonged immobility itself is a risk factor for worsening your osteoporosis. So you are worsening your osteoporosis and you are losing your muscle strength, and DVT and pressure source is another thing. So these are the pressures. PE and DVT are the main risk factors for these patients to have a sudden deaths. And also, what about the pain management? And these patients end up having the pain and they go on the opiates, and prolonged opiate use causes you constipation, drowsiness, and aspiration during their sleep. And all these affect their lung capacity and pneumonia. And pneumonia is the second most common cause after DVT and PE in these patients as a cause of death. And they will be suffering for the pain, give or take 3 to 4 months time. And most important thing is, when you say, yes, after 3 to 4 months, the fracture will heal, what do you call as a healed fracture? Do you want to heal your fracture healed as the picture on your right side or on the left side? Because with the conservative management, you are never going to restore your height. Once the height you lost is lost, and that is going to put an undue stress on the vertebral bodies next above and below, which can facilitate fracture again in those levels. So there is no way you are going to restore your height, and then you are leaning forward over a period of time because of that height loss. Next slide. And this is the data collected from the government. And it is based on their Medicare patients, which means most of them are more than 65 years. Patients who were managed with a kyphoplasty have a relatively less hospital stay, that is almost 3.7 days compared to the 7.4 days of patients who are just managed with the pain conservative management. Next slide. And similarly, the patients who had conservative management had higher chances of getting admitted to the hospital again after discharge. Next slide. And patients who had a kyphoplasty has a more likelihood of getting discharged to home rather than going to an assisted living facility or a nursing home or rehab facility because of the pain management and improvement. So this is the natural course of a vertebral fracture if you leave it untreated. Nobody wants to end up in a wheelchair. Everybody, we are born to stand erect. And I believe it is a fundamental right for the patient to have enough pain control and have enough quality of life. But it is our responsibility, combined with the patient awareness, where we can stop happening in this process. Next slide. And this is one of my patient. She is an 86-year-old who has a fracture, And family had a lot of back and forth saying to do or not to do. Finally, because after waiting for a couple of months, they came in and get it done. And daughter was so happy, and she sent a video of her this thing. Yeah, this is the patient. And for 2 months, she started to have that walking aid, and now that is how she is. Next slide. Any questions?
I think there's a lot of questions.
there are a lot of questions coming in.
We need to be here all day.
So let me start with one from Tanya, who asks, what kind of doctor offers this to patients? And should a doctor be on top of this, or is it the patient's responsibility to have osteoporosis addressed?
So generally osteoporosis, usually your primary care physician, oftentimes the gynecologist, these are like the first doctors that screen for it, or they suspect it, and then they refer to either an endocrinologist or a rheumatologist that treats this. And we tend to refer, if I see someone with a vertebral fracture that meets the criteria, I would definitely refer to Dr. Boddu, for consideration of kyphoplasty or vertebroplasty.
Okay, Diana is asking if someone is allergic to many things, including adhesives, is it possible to be allergic to that cement?
So far, I have not seen anyone who is allergic to the cement. No, technically it is a combined with some barium material, which is in, what is that? It's a medically inert material.
Okay, question on the medication slide. Do different meds affect the spine and the hip differently, and how does that work?
Yes, so the selection of the proper treatment for osteoporosis depends on a lot of factors, including how old you are, how high the risk is, where is the low bone density, is it more at the spine, more at the hip? Because some medications have a better effect in the spine, some also at the hip. For some, we don't have data for reduction of hip fractures. So yes, there's different medications that we use for different indications. For example, I may not use something like raloxifene, which is a cousin of a medication commonly used in breast cancer, tamoxifen, in an older postmenopausal woman at risk for hip fracture, because we don't know if it prevents hip fractures. So I might opt to choose this in a younger woman who's not at a high risk for hip fracture, just to give you an example. Or if someone has a very poor bone quality, they already have vertebral fractures, right? So they're at high risk of getting more. We know their bones are really badly constructed at this point. I may choose to offer an anabolic medication, something that builds bone, because they can definitely improve that structure as well as improve the bone density. So it does take a whole lot long discussion and full assessment. Every patient is different.
We have two questions, one about diet and exercise. One is, does low acid diet prevent loss of density? And another is, does regular exercise improve bone quality?
So does low acid diet? No, low acid diet is not something that's generally been shown to, I don't even think it's been looked at to see if it increases bone density, but the diet is very important in general. Diet full of calcium, that's rich in calcium, right? Dairy products, dark leafy vegetables, diet that is rich in natural antioxidants, like all types of vegetables, all colors, and fruit. And diet that has a normal amount of protein, not excessive protein, diet that is not excessive in red meat products because they have a lot of phosphorus and that makes your body leak calcium. But we do want to have enough protein, especially animal protein as well. So diet that does not include excessive caffeine, right? We discourage excess alcohol or caffeine as well. So it's hugely important as far as being able to reduce the rate of bone loss and maintain bone structure as much as it can. Now, diet and supplements and exercise, they're cornerstones of reducing rate of bone loss and maintaining bone strength, as well as muscle strength, so that you minimize falls, right? You're stronger, balance. But they're not enough to reverse the osteoporosis and have a significant reduction in the risk of fractures. So for that, unfortunately, we have to recommend medications, which are overall well tolerated and very effective.
Okay, the next question is, does the Dowager's hump only happen with a fracture?
Dowager's hump, mainly with multiple fractures, but of course people can get kyphosis from like poor posture all their life because of the muscles weaken in that area, or because you know, the discs in between the vertebrae get thinner as we age, right, Dr. Boddu, maybe?
Yes, yeah. It is mainly it's multiple fractures is the top of the list, and also you will, when you have the patients are using the brace, that is another reason in the conservative management. If they are having a prolonged bed rest or using the brace for longer time, their back muscles are getting weaker. We are blessed with the ability to stand up straight because your paraspinal muscles, those are the back muscles, are holding your spine like a bow and arch. And once they become weaker, you start to lean forward. And that is where these two things happen.
Okay, Sally is asking if you can talk a little bit about the type of osteoporosis that's resistant to Fosamax.
Osteoporosis that's resistant to Fosamax. So Fosamax is a lendronate, right? It's a medication that decreases bone resorption. It stops the bone breakage of the cells that do the bone breakdown. Resistant to alendronate. Most patients respond well to these types of medications. They're kind of our first line treatment. There might be a 10 to 15% of patients that are non-responders. I wouldn't call that resistance. It's just that their cells don't respond as well to these treatments. And we don't have a way of predicting that, unfortunately, unless we actually try and see that the bone density isn't improving, or hopefully not, someone fractures. But yes, not everybody responds to a treatment. But I wouldn't necessarily call that resistance. It's just lack of response.
Right. Therese is asking about toxicity and risk of some of those medications with the higher effectiveness.
Toxicity and risk. Of course, there's no medication that does not have side effects, including, you know, Tylenol, Advil, all the things we use on a daily basis. Overall, for the benefit you get with these drugs, they're very safe. There's some side effects that are common in all of them. So about, 10% of people may feel achiness when they first start one of these medications. That's usually self-limited and goes away. The oral medications have to be taken a certain way so that they don't cause heartburn and reflux. So we avoid giving them to people who already have these underlying issues. So these are kind of the most common side effects. There's certain limitations in their use. For example, we cannot give alendronate that was just mentioned, and that family of medications long-term. They're drugs that we give for 3 to 5 years or less because they accumulate in the bone. So we want to prevent complications from long-term treatment that we rarely see. They're very rare, but still we want to prevent them. So whereas others can be used, for more long-term. So overall, they tend to pretty well tolerated. I don't know if there's some specific concern for a specific side effect that someone might have read, but.
We've got a couple of questions on Reclast Infusions.
So Reclast Infusion, that's Solendronate. That is a medication that is a cousin of alendronate that was just mentioned. Again, it's a drug that slows down the bone-breaking cells, accumulates in the bone. It's given intravenously, so it doesn't cause any problems with heartburn. But about 20% of people that take this may feel like they have the flu for 3-4 days afterwards, after the first infusion. Again, there is no way of predicting that. Not very easy to predict it, but it is self-limited. It just requires rest and hydration, Tylenol, Advil, and it does go away. Another concern with Reclast comes from our favorite doctors, our dentists, because these drugs they stop bone resorption, they slow down generally healing in the bone. Part of what those little cells do is they initiate healing of little cracks in our bone. So if you have a dental extraction, for example, they could potentially delay healing. Or if you do a dental implant, they could potentially delay healing as well, mainly with the intravenous medication. So often I get, calls from dentists about when they got the treatment. We try to discourage elective procedures right after an infusion, but they can definitely be done later. And I have to point out that even the American Dental Association and the Oral Surgeons Association in America, they specifically say that patients at high risk for fractures should not interrupt treatment or withhold treatment for dental work. But of course, we do try to work well with oral surgeons and dentists and make sure everybody gets the desired procedure and in their teeth and their mouth and still gets treated for the osteoporosis.
Okay, Dr. Boddu, maybe you can address this one. Marianne wants to know if you have any comments about studies that suggest kyphoplasty can cause nearby fractures.
That's a very good question. I think the paper already came up in 2007. So the whole question comes from that paper where they reviewed retrospectively looked at 36 patients. And they said, oh, there is almost like a 6% risk of having a new fractures with the following a kyphoplasty in the adjacent levels. But if you look at it, the fundamental problem is once you have a fracture, if you don't do anything, your risk of having the second fracture is 5 times higher. And if you have 2 fractures or more, the risk of having the third fracture is 12 times more. So that means it is the osteoporosis that is causing the fractures at the next levels. And when we treat the fracture, we are only addressing that fracture. And you can guarantee that there won't be another fracture at the treated level, but the other levels are still at the risk. The other vertebral bodies and hip and wrist are still at the risk of having new fractures. And there is a study, prospective study done in 2009 that shows there is no significant difference between patients who are treated conservatively versus patients who are treated with the kyphoplasty in terms of having adjacent new fractures.
And I should point out that if you have your kyphoplasty, but you treat the osteoporosis, right, then you start an appropriate medication to reduce risk of future fractures. So that would definitely minimize, this
is the key.
fractures. That's the key. It's both.
That is the key. It is when we do the kyphoplasty, we are not treating osteoporosis. We are treating only the manifestation of osteoporosis, which is that specific fracture. But you still have osteoporosis all over the body. And that's why once we see the patients treat for the compression fracture, then immediate question is, do you have an endocrinologist or not? If not, then yes, they have to see. With all these medications, otherwise they are going to come back with the new fractures.
Right. Teresa is asking if there's a relationship between osteoarthritis of the spine and osteoporosis and fractures.
It's mainly the immobility. With the worsening osteoarthritis, either even it is in the spine or hip or in the knee, that makes you more sedentary, and if you are refusing to walk or perform exercises, then that worsens your osteoporosis, and that will cause your fractures.
And we have a question asking, how do you know that you have one of these fractures, especially if you already have spine issues that give you chronic pain?
It is a new different type of pain or sudden worsening of a chronic pain.
Or height loss, you just shrink.
Yes, by the time you have the height loss,
it's late.
You already diagnosed a fracture. There is no more suspicion at this point.
Okay, and then probably we have time for one more question. A lot of people have asked about exercises. What kind of exercises for paraspinal muscles, weight-bearing exercises? What's the best kind of exercise regimen to follow?
It is normally we say it is following the Kypho. We encourage them to do mainly the spine flexion and extension. Either you are standing up or lying down. It is a spine flexion and extension exercises are the key to strengthen the paraspinal muscles. But we will make sure it is the, I don't know, Rosen, if that is a possibility, we can just add a sheet with pictures of the exercises with this one on the YouTube.
And generally,
you can do that.
For osteoporosis, generally anything that is done with an element of resistance or against gravity helps your bones, right? It keeps those bone forming cells alive and awake, so that they're able to keep forming bone. So that could be fast walking, brisk walking. It can be jogging, running, treadmill, the machines and the gym when you go, your classes, your Zumba. Yoga, except specific movements in yoga like over flexion and over twisting in the spine. So anything that you do regularly can actually help maintain bone mass, reduce rate of bone loss, maintain strength and balance. So that's very important. There's two types of exercises I always say that are great for your joints, but don't really help your bone mass. They're not bad for osteoporosis, but they don't really help. And those are swimming and bicycling. So if you like those, that's wonderful. Just don't rely just on those types of exercises. You have to add something with weight bearing and resistance element.
Okay, well, thank you both very much. And thanks to everyone for attending. This will be available on YouTube, and we can add a link to an exercise list. Thank you so much.
Thank you all.